Welcome to our presentation on Cephalopelvic Disproportion, a critical topic in obstetrics. Cephalopelvic Disproportion, or CPD, is a pregnancy complication where there is a size mismatch between the pelvic and the fetal head, making childbirth challenging. Several factors can lead to CPD, including a contracted pelvis, nutritional deficiencies, developmental issues, a large baby, and malpresentation. A contracted pelvis is anatomically defined as a pelvis where one or more of its diameters are reduced below the normal by at least 0.5 centimeters. Understanding the dimensions of the pelvic inlet, cavity, and outlet is crucial in diagnosing CPD. Obstetrically, a contracted pelvis is one where the reduced diameter interferes with the normal mechanism of labor. Various factors influence the size and shape of the pelvis, including developmental, racial, nutritional, sexual, metabolic factors, and trauma or disease. There are different types of pelvis shapes, such as gynecoid, platypuloid, android, and anthropoid, each affecting childbirth differently. Development defects like Naegele's pelvis, where one side of the sacrum is absent, can contribute to CPD. Robert's pelvis is another developmental defect characterized by the absence of both sacral alae. In high assimilation pelvis, the sacrum is composed of 6 vertebrae, which can impact pelvic dimensions. Low assimilation pelvis is identified by variations in the sacral vertebrae, affecting pelvic structure. A split pelvis, marked by the absence of the symphysis pubis, can significantly alter pelvic mechanics. Structural defects like scoliosis, kyphosis, and lordosis can influence the shape and function of the pelvis. Evaluating CPD involves a thorough diagnostic process to understand the underlying causes and implications. A detailed history examination includes looking into past medical conditions, obstetric history, and any trauma or disease affecting the pelvis. General examination assesses physical attributes such as gait, stature, and signs of rickets or dystrophia syndrome. Abdominal examination focuses on the engagement of the fetal head, the shape of the abdomen, and any malpresentation. Pelvimetry involves measuring the pelvic diameters through clinical and imaging techniques to assess CPD. Cephalometry measures the fetal head dimensions, including biparietal diameter, occipitofrontal diameter, and head circumference, to evaluate CPD. Welcome to our presentation on management in obstetrics. We'll explore various aspects of managing labor and delivery, focusing on key concepts and procedures. Disproportion in labor can vary in degree. Moderate disproportion often allows for vaginal delivery, whether preterm or term. Management may include labor induction, cesarean section, or trial labor. Trial labor involves spontaneous labor in cases of moderate disproportion, conducted under supervision in a medical institution. The goal is to achieve a vaginal delivery while closely monitoring the progress. Certain conditions contraindicate trial labor, such as elderly primigravida, malpresentation, gestational hypertension, moderate to severe CPD, and previous failed trial of labor. Prerequisites for trial labor include a young primigravida, no outlet contraction, vertex anterior position, absence of other obstetric complications, and facilities for continuous fetal monitoring. Conducting trial labor involves several steps: blood grouping, consent for LSCS, shaving perineum and abdomen, starting IV fluids, assessing general and fetal conditions, monitoring labor progress, minimizing vaginal examinations, providing adequate sedation, and considering vacuum extraction if necessary. If labor progress is unsatisfactory or fetal distress occurs, a cesarean section is performed. Success is defined by the birth of a healthy baby via vaginal delivery, forceps, or ventouse, with the mother in good condition. Severe degrees of disproportion or contraction, absolute contraction, dead fetus, or patients unfit for trial labor necessitate cesarean section. These indications guide the decision-making process for severe cases. Complications can arise during pregnancy and labor. We'll discuss maternal and fetal complications, highlighting the importance of timely and effective management. Maternal complications during pregnancy include malpresentation, pendulous abdomen, non-engagement, and pyelonephritis. During labor, complications such as inertia, slow cervical dilation, prolonged labor, PROM, cord prolapse, uterine rupture, and pelvic joint injury can occur. Fetal complications include intracranial hemorrhage, asphyxia, skull fracture, nerve injury, and intraamniotic infection. These conditions require prompt and appropriate intervention to ensure the safety and health of the baby.